Hello everyone, welcome back to Mastering ECG workshop. Today I've got a new ECG challenge for you. We are going to use a 70-step approach to interpret an ECG. So grab a pen and paper and let's get started. Imagine you are in the emergency department. A 66-year-old lady comes in with a history of central chest pain radiating to her left arm and jaw for the past 2 hours. She has hypertension but no history of ischemic heart disease. Here is her ECG. Take a good look. Please use the 70-step approach to interpret this ECG. You will have 10 seconds for each step. I will provide the answers after each step so you can compare your findings. Step 1. Determine the heart rate. You have 10 seconds starting now. The correct answer is 75 beats per minute. You need to divide 300 by the number of big squares between two QRS complexes. Here we have got 4 big squares, so 300 divided by 4 is 75. The step 2 is assess the rhythm. This is a normal sinus rhythm as there are P waves before QRS complex and the heart rate is 75 beats per minute, that is within normal range. Step 3 is looking at the axis. Your 10 seconds start now. The answer is there is left axis deviation as the QRS complexes are predominantly negative in leads 3 and AVF and upright in the lead 1. Please see my other videos for the details on this topic. Links are provided in the description of this video. The step 4 is examining the relationship of the P waves and QRS complexes. Is it normal or not? In this ECG, there is a normal relationship between P waves and the QRS complexes as each QRS complex is preceded by the P wave. The step 5 is to measure the PR and QT interval. PR interval is measured from the beginning of the P waves to the QRS complexes. Normal PR interval is 0.12 to 0.2 seconds, which is 3 to 5 small boxes. Here there are roughly 5 small boxes, so the PR interval is 0.20 seconds, that is, it is normal. For corrected QT interval, I use the online calculator like mdcalc.com. In this ECG, the corrected QT interval is 360 milliseconds, which is within normal range. The step 6 is to analyze the QRS complex, whether they are broad or normal. In this ECG, the QRS complexes are normal. Now moving on to the next and final step, which is step 7, which is assessing for STT changes. Here we are looking at if there is any evidence of ST segment elevation, ST segment depression or T-wave inversion. Your time starts now. In this ECG, there is evidence of ST segment elevation about 1 mm in the lead 1 and maybe about 0.5 mm ST segment elevation in lead AVL. There is also ST segment elevations about half to 1 mm in the leads 2 and V5 and V6. To diagnose ST segment elevation MI, there needs to be ST segment elevation of at least 1 mm or more in contiguous limb leads For example, in this ECG, there is ST segment elevation in lead 1. To be diagnostic of acute MI, there needs to be ST segment elevation of 1 millimeter or more in lead AVL. And for the inferior leads, it need to be contiguous changes in leads 2, 3, and AVF. For chest leads V1 to V6, there needs to be ST segment elevation of 2 millimeter or more in the contiguous leads. Please find my video on how to diagnose ST segment elevation MI in the description. So with this definition, our patient does not fulfill the criteria of acute ST elevation MI, but the presenting symptoms and the ECG changes are suggestive of evolving lateral wall MI. She should have serial ECGs and be referred to the cardiologist for further management like primary PCI. Did you make the correct diagnosis? Let us know in the comment below. Remember, practice makes perfect, especially with ECG interpretation. Until next time, keep learning and I will see you in the next ECG challenge. Goodbye.